Welcome, my friends. I'm Dr. Konstantinos Triantafyllou from Athens, Greece, and I welcome you to this Wednesday webinar. This evening, we have a very interesting topic. We will discuss what ESGE can do for you to help you measure quality. And you all know that quality is one of the most important issues that we currently face and we currently discuss. Dear colleagues and dear friends, as you already know, this is the fourth consecutive year that ESG offers you the opportunity to view high quality presentation on the hostess endoscopy topics from the world leaders in endoscopy. You have the opportunity to interact with the speakers and to participate by submitting online questions. So please focus on the bottom of your screen where you can find the Q&A function where you can pose your questions, which we will try to answer during the discussion session. And of course, it is this activity, the webinars, the AG webinars are for free. And it's a great pleasure now to briefly introduce our colleagues. It's Professor Raf Bisschops, who is the head, the chair of the Quality Improvement Initiative of the ESGE, Professor Miguel Areia, and Dr. Marek Bugajski. Thank you for participating to this webinar. All of them, under the guidance of Professor Bisschops, have developed this application, which we will discuss today, and they have tested it and they have used it, and they will share their experience. Dear Raf, thank you again for being with us. Thank you again for working for the ESG so many years, for developing this fascinating project. And you have the microphone.
Thank you very much, Kostas, for your kind introduction and for organizing this webinar. So why do we have to measure quality and how can we do this? How can we as ESG help you with that? That's what the first part of this webinar will be about. You can see that, these are my conflict of interest, that there is a difference. There is actually a difference between different endoscopists. And as doctors, we should actually provide the best possible care for our patients. And evidence exists that performance measures results in better outcome. It can help to protect patients from developing cancer. It can lead to fewer complications and better patient satisfaction. But also very important nowadays is cost effectiveness. It can lead to fewer repeat procedures and fewer additional treatments if we do a good job in the first place, in the first attempt. We do miss lesions. That's why we need to measure quality, because the detection of lesions is directly linked to what happens to the patients. From this meta-analysis, a polyp miss rate of 22% was reported, and this also accounts for polyps that can measure more than 10 millimeters, which can be missed in 2% of the cases. And we know that not all endoscopists are the same. This landmark paper from already 14 years ago showed that there is a real distinct difference in the number of adenomas detected per subject screened amongst different endoscopists in the study. And this led to a different adenoma detection rate between the different subjects according to the endoscopist, which in this fact was directly linked to the time spent during withdrawal by the respective endoscopist. So this indicates the importance of taking the time to look for polyps. And then you need to have a good enough adenoma detection rate. This other landmark paper set a bar for adenoma detection at 20%. If you go below that, you can see that the risk of having interval cancers increases. So quality directly relates to what happens to the patients if the job is not properly done. Each 1% increase in adenoma detection actually leads to a 3% decrease in colorectal cancer risk, as indicated in this study, including more than 300,000 colonoscopists by more than 130 endoscopists, with an ADR ranging between 7.4 and 52.5%. And if they compare the highest versus the lowest ADR quintiles, there was actually a hazard ratio reduction for post-colonoscopy colorectal cancer of 0.52, and this was applicable to colorectal cancer, advanced cancers, and fatal colorectal cancer. So it's actually important. And also what we do with the polyps is important. Incomplete resections of polyps is something that can happen. In 10% of the cases in this study of 5 to 20 millimeter polyps, they were shown not to be completely removed when the margins were sampled. And here again, there was a threefold range between different endoscopies. But it's not only in the colon that quality matters, also in upper GI. And later on, Miguel will tell you more about that. 7.2% of the gastric cancer patients did not have a lesion detected at previous endoscopy that happened within 12 months. And there's also here a difference between endoscopists, as shown by this Singapore study, making a differentiation between slow and fast endoscopists with a cutoff of 7 minutes. They could see that those spending more than 7 minutes had a high risk lesion detection rate of 14% versus 6% and more dysplasia and cancer detection. So again, time matters. Also for Barrett's, this landmark paper from Denmark, including 11,000 patients with Barrett's, showed actually that in the first year of follow-up, which was the majority of the cases, that almost 40% of the cases of adenocarcinoma and high-grade dysplasia were prevalent cases because they were detected within 1 year of the first endoscopy. And it is difficult to detect lesions. When patients are referred with suspicion of neoplasia, and they are inspected by an expert endoscopist, like here in AMC, they actually, if they are referred without a lesion, which happened in 40% of the cases here, in 3 out of 4 of these patients without a suspected lesion, they actually could find a lesion, and note that even 4 patients were sent directly to surgery without any attempt for endoscopic therapy. So there is a room for improvement. Over the last couple of years, ESGE and UEG have developed performance measures and quality indicators for all fields in endoscopy, and they have now all been published. And after the publication, it's really time for implementation and widespread dissemination. It is actually, in fact, time to start to measure in your own unit, and there are different solutions for different situations. We know that electronic reporting is important. And if you're in the situation where you have a full electronic report with standardized protocols and an automated capture and feedback of performance measures on service and individual level, which actually exists, for instance, in the United Kingdom and for some part in Holland, then you actually don't need the quality check app that we're going to talk about. But in other situation, which I think accounts for the majority of the endoscopists, you can have a full electronic reporting system with standardized protocols, but no automated capturing of the performance measures. Or in some cases, you may even have non-standardized reporting systems or with free text or paper reports. And then obviously there's also no automated captures of performance measures. And in these 2 cases, I think we can help you out, still measuring the quality of what you're doing by using the ESG Quality Check app. How can you apply for this? It's very simple. You go to the website and there you can see the ESG Quality Check app page on the ESG website, or you can go from the ESG membership dashboard where you have to log in. And then you can get to this screen where you can simply request to get access to the app. You put in your hospital and you request when you when you will actually do the audit of your unit. You simply submit it. And after submission, the login credentials will be sent to you via email a week before the selected 4-month time period. If you want to hear more about it, just don't hesitate to contact the Secretariat at quality@esg.com. Then how to use the app. It's not meant to use or you don't have to measure every single endoscopy that you're doing. Actually, 100 to 300 cases are enough. If you look here at what happens to the statistical significance of what you're doing, if you already select 100 cases, the 95% confidence interval ranges between 84 and 96%. And this becomes better going from 200 and 300 cases. But if you go to 1,000 cases, actually, this becomes a little bit more narrow, but not so significant. So probably if you just do 100 procedures per quality indicator, that will be enough. So we estimate that entering 200 to 300 gastroscopies and colonoscopies suffices to get a good quality snapshot of your service. And this is something you can actually sell to your hospital administration. Probably if you have somebody from the quality improvement committee in your hospital that can help you out with the administration of this, and they can allocate that person for 1 to 2 weeks to your unit, you can actually do a yearly or 2-yearly audit by these numbers. Then how to use the app. Just remember, it's not a prospective audit tool where you enter everything immediately, because for many cases you will have to enter histology, and Marek and Miguel will show you that in a minute. You just input 100 to 300 consecutive endoscopy reports from a time window in the past without selecting the indication. And we developed a flowchart that was incorporated in the application that will automatically present the necessary input depending on the indication of the procedure and or the type of the procedure. And this makes it easier, so you don't have to select procedures according to the performance measures that will be done for you. And then during the data entry, you will get immediate feedback. At this time, the upper and lower GI are ready, and we will address them tonight. And the others will be developed and normally will be available during ESGE days. How long can you use the app after registration? Well, we have foreseen a time frame of 4 months, so please plan your audit. And this is to be able to accommodate as many people as possible. So engage yourself and your colleagues to upload at least 100 cases for upper and lower GI within that time frame. And you may wonder what ESGE is going to do with all this data. Well, actually, everything is anonymized regarding patients, so there's no patient data entered as such, and the ESGE in the app only records the uploading person. We will use this to create a benchmark to show to other people what is the average within the participating centers or participating endoscopists. And we also you will use this to adjust the performance measures in the future, see what is relevant and maybe less relevant or more relevant than another one. And hereby evaluating also the applicability of the different performance measures. And in the end, you will be able to use the data from your own center to have an immediate feedback regarding your own department and the performance measures, if you reach them or not. And this can then be evaluated against the benchmark that we will develop with all this data. So this is, in a nutshell, what we have been doing and why I think that measuring quality is important. And in the next couple of minutes or the next half hours, it's my pleasure to introduce Professor Miguel Areia and Dr. Marek Bugajski, who were heavily involved in developing the app, and they had to endure all the pain to develop this. So kudos on them to finish this good job. Unless maybe Miguel or Marek, we want to discuss already some questions first or discuss something in essence. I don't know, Kostas, if there are already questions that people want to ask.
Thank you, Raf. Okay, no, not yet. We don't have any questions. Our attendees are looking forward to continue with the presentation. And
Okay.
Miguel, please.
And we start with Marek then, I think, right?
Yes. Hello, everybody. Thank you for the possibility to talk a bit about the lower GI app, and for the possibility to work on it, because it was quite an experience. So first of all, I have no competing interests. I want to talk shortly about what parameters are monitored through the app. And we here relied heavily on the guidelines published by ESGE on performance measures for lower gastrointestinal endoscopy. They were published a few years ago, but I hope that you will see that we managed to incorporate all of them, not only the key performance measures that were selected, one per each domain, but also all the minor performance measures. So starting from the pre-procedure performance measures, of course, the rate of adequate bowel preparation will be captured through the app. This is of course the most important one, and the important thing is here that all validated scales can be used for this. So regardless of which scale do you use at your unit or you personally, you can use it in the app as well. We also capture minor performance measures like time slot for screening endoscopy. This includes both primary colonoscopy or FIT positive patients. And we also ask about the indication, which is the most, in fact, the most important question, because it determines which pathway and what questions will be asked by the application. Going straight to the procedure performance measures, we capture, of course, all the key performance measures. These are the most important ones, so cecal intubation rate and adenoma detection rate, as well as the appropriate pulpectomy technique. But here it is understood by using a snare for all lesions that are larger than 3 millimeters. This is the most important part. But also, depending on what polyps were excised in the colonoscopy that you are putting into the application, other minor performance measures will be captured as well. First of all, withdrawal time and polyp detection rate will be used. They are, of course, more important if the adenoma detection rate that is calculated is suboptimal or is impossible to determine. But regarding the polypectomy technique, there will be questions also about polyp retrieval rate, tattooing the resection site in case of some lesions, using advanced imaging, and adequate description of polyp morphology, mainly using the Paris classification and LST classification. And going back to the last part, so the post-procedure performance measures, the application will be captures also data on complications, patient experience, whether it was measured or not, and it will ask if the appropriate surveillance recommendation was given to the patient. So all performance measures that were proposed by the guidelines, they're incorporated into the application. So going swiftly to using the application, you will see in a moment a short video of case input. You will see that it's quite short, but before, please take note of these few tips. First of all, as Raf mentioned, always add only retrospective cases, because histopathology result is needed, mainly to calculate adenoma detection rate, of course. If the indication is unknown, there is such an option, because it may happen. Then, as I mentioned before, indication determines which questions will be asked. And if there is unknown indication, please remember that the colonoscopy will be treated as screening colonoscopy, which would trigger the largest loop and would trigger the largest amount of questions. Some performance measures are calculated after 30 procedures. This applies mainly to the adenoma detection rate, and such information will be shown on the application only after inputting 30 procedures. Then the parameter will be calculated, because only then it is more or less reliable. After finishing a case, sometimes the web page needs to be refreshed in order to start a new case. It's just a quick technical tip. And now you will see the recording of me inputting the case, as well with my commentary. But please bear in mind that this is still a test version of the application.
So this is the beginning of the lower GI app. This is in testing still, but you will see only one choice for you. I open it. I want to add a new case. It was not an emergency procedure. It was a screening for colorectal cancer. Now the first calculation for performance measure is already done. It bases on all the colonoscopies that you've already used. The scale with which we assessed the bowel preparation was Boston bowel preparation scale. However, the patient did not have all segments of the bowel, so I can choose that he was missing an ascending colon, and I use the scores for remaining segments. And the patient had adequate preparation. Was the colonoscopy complete? Was the photo taken of the cecum? And the calculation happens immediately. A polyp was detected. The patient was aged 50 or older, and it was an adenoma. This performance measure will be calculated after 30 colonoscopies. The polyp was removed, and now the app asks us about the largest polyp that we removed. So it was a 1S, for example, and 2A. We can combine, but the lesion was not an LST, and we use Paris classification properly. The polyp was at least 2 centimeters, and we removed it through EMR, but we did not do a tattoo, so this is failed. The polyp was of course retrieved for histopathology assessments, and there was no immediate complication. The patient was not hospitalized in 7 days after colonoscopy, and the patient did not die in 30 days after colonoscopy. We know that because we had patient feedback in both cases. Patient experience was measured. We used GRS. And the patient received a written surveillance recommendation, and there was no deviation. And this is the whole case finished.
Okay, as you can see, quite complicated case can be put in the application in matter of three to 5 minutes. So it's quite easy to use, even though there are many parameters that are captured. So that's all about how to use the application. Raf mentioned in the beginning that the best possible case is to have a digital database that enables capturing all the data. And I just wanted to show you how we measure quality in Poland in Polish colonoscopy screening program, because we are fortunate, and this is of course a hard work that lasted many years and is still in progress, that we have created a dedicated database in the screening program that was designed in a way that we capture the quality, and we are able to control the quality throughout the whole program. The database enables us to create a tailored reports. They can be accessed on a center level or on individual endoscopist level, and it encapsulates different parameters. You will see that in a moment. And that's possible because we would coded fields for many coded fields, mainly for endoscopy completeness, most advanced lesion categorization, which allows us to calculate adenoma detection rate and other performance measures. There are fields for bowel preparation. We use a Boston Bowel Preparation Scale. We assess what was the polypectomy technique, and we also include patient-reported satisfaction and many more aspects of colonoscopy. This is the exemplary report after the colonoscopy. As you can see, there are many fields, but this only looks complicated. To fill it in, it takes about three minutes tops. So it's quite fast, and we capture a lot of data through it. Later on, the database also includes all histopathology reports that are linked with the colonoscopy report. And when looking at both the histopathology and the colonoscopy report, we use the most advanced lesion categorization. As you can see here, we just click for one of the most advanced lesions. We check which lesion was it, and this allows us to create tailored reports, which I'll show you on the next slide. Also, one of the newer functionalities is complications assessment. We did a randomized trial that was published. The results were published in Endoscopy International Open. We used, and we are still using it because we implemented it live on the national level, automated telephone complications assessment that is done 30 days after colonoscopy. So we automated the patient feedback. And all this allows us to access tailored reports. This is an example of a report of one endoscopist with his secum intubation rate, adenoma detection rate, advanced adenoma detection rate, etc., etc. Sometimes we have still, of course, problems that the data may be incomplete because of case referrals and similar issues. Sometimes there is missing data, although when looking at the size of our database with hundreds of thousands of entries, then still the missing data is really a small margin. And also one of the newer reports that we incorporated, each endoscopist can check his painful colonoscopy rate, and each person can check himself in comparison to all other endoscopists. So you also can see how well are you performing in terms of the whole program. And lastly, how we did, because we do this to not only for people to access the data, but also to capture the people that are underperformance, and how do we deal with it? First of all, the access to reports is constant. Everyone can do it on the fly every time they need to. We try to provide as much feedback as possible to both centers and individual endoscopists throughout the country. But we also have two initiatives, training initiatives with underperformance. One is based on the paper that was published by Michał Kamiński a few years back on leadership training to improve adenoma detection rate, and it works really, really well. And now we have an ongoing randomized controlled trial on training to reduce painful colonoscopy rate. We hope that it will allow us to introduce this dedicated training in the curriculum of endoscopists in Poland. Of course, in the worst case scenario, if there is still suboptimal secum intubation rate and adenoma detection rate on the center level, the last resort measure is that we do not us, but the Ministry of Health does not prolong the contract for screening colonoscopies with the particular center. And that's all from my side. Thank you very much.
Well, thank you very much, Marek. I think it was very clear. So I don't know if there are already questions, Kostas.
Thank you, Marek. No, Raf, yes, you and myself, we have also already answered some brief, I might say, introductory questions. I mean, we have not entered in the essence of the application yet. So hopefully we'll have more questions for discussion after the presentation of Miguel.
So I had a question for you, Marek, regarding the underperformance, because sometimes measuring quality could be perceived as, you know, as a police job, right? So that people come in and see what you're doing. But I think, well, especially from ESG side, this is not the goal of what we have been doing the last couple of 6 years. The end game is to really improve quality. So how successful are you in if you give the feedback that you actually show to them if the performance is not good enough, that you can help to improve people? Have you any numbers on that?
Yeah, actually, I didn't include it in my presentation, but we can see a gradual increase in adenoma detection rate throughout the whole program since the beginning, because it started 20 years ago. So of course, it's very hard to compare the pre-2010 numbers to current numbers. But even for the last, I would say, 6 to 7 years, we see a gradual increase, and we reached, as the whole program, the 25% threshold, I think 3 or 4 years ago. So this is, I think, this is the utmost indicator that the job through all these tools that we provide is done. One last comment that I would like to add is, because you said that it's a police work, and we really would not like to be perceived as such, because there are numerous papers on different aspects that on different fields of gastroenterology, but in medicine as well, that the pay-per-performance approach is not the way to go, because it does not bring the appropriate effects, and it's always training and it's always feedback that works best.
Okay. So, but if I understand well, the situation in Poland is obligatory. If you participate in the screening colonoscopy, you have to comply with this system, which I think also entails double entry. Is that correct?
Yes and no. You have to comply with the system, and you have to input all the data and all the reports, colonoscopy and histopathology, in the database in order to participate. There are some centers that still do the double input, because they first do all of it in their internal system, and then someone, usually administrative personnel, copies it to the dedicated database. But it changes, and now it's really a rare occurrence, because the reports that are printed out from the database, they are perfectly fine with all the Polish regulations, and they are like official results. So people see that it's easier just to use only our database.
So having answered this way the question of Raf, to my curiosity, has the department or the Minister of Health has obligated the endoscopes providers, I mean the companies, to provide a system which is compatible with all the endoscopes, or your database does not actually communicate with the endoscope system?
That's a question for me.
Yes.
Yeah, we are using it outside of the endoscope systems, so it's completely independent, and it does not matter which company endoscopes you're using. The database, each center first needs to input all the endoscopes that they use, and then on the colonoscopy report you just check, take from the list which one was used.
But do you also download in the report? Do you download pictures like the cecum? Do you do it directly from the endoscopy system, or?
Yeah,
it's a little bit technical, but you know there are different options throughout Europe. There's a lot of diversity. People might be interested in contacting yours or someone else from the Ministry of Health in Poland, where we know that the screening program is very well organized, and it's I say it's closer to countries like mine, while the British system is far away in terms of being fitted in our needs.
Yeah, unfortunately, the photo documentation is our Achilles foot, and it is not included in the database. And this is, I think, the only remaining reason why people still, in some places, use the double input, because their other systems are connected with the endoscopic systems, and they allow for photo documentation. Here, it's possible, but it's quite tedious, and we would like to introduce it, but it's quite a complicated matter to do on our own and to make it work with all the different systems. And there are always some other more urgent matters to attend to. So this is the I would say one of the weaknesses of our system, that we have no photo or video documentation.
Now, if you allow a final question for our attendees, since Marek, you are an expert now in using the application. Does the application provide this accelerated adenoma detection rate?
No, it does not include this performance measures, because it was not included in the guidelines. So that's the main reason why it's not included. Yeah.
Yeah, just as on a note, I mean, this is something in progress, and Marek is involved in the working group for colonoscopy and quality in colonoscopy, and over the next couple of years we will maybe revising these performance measures, and it may be included or not. That's something that we will see in the future, but maybe we should start with what we have now. So thank you very much, Marek, for pointing that out and also showing what you can do on a national level. And I'm sure you have this now for colonoscopy, but for gastroscopy, you don't have anything, do you?
No, unfortunately not, but this is a
Okay.
very daunting task, as I assume Miguel will show
Exactly.
in a moment that it's a bit more complicated than colonoscopy.
So you will still be in need of the app that Miguel helped to develop. So please, Miguel, introduce the upper GI app.
Okay, so Raf, Kostas, Marek, and all other, thank you for attending this webinar. So now I will show, repeat some things that Raf and Marek already told, but show how it works for the upper GI tract. So I have nothing to declare on my disclosure. So just some quick reminders. So always use this as a retrospective app, because in lower GI, as Marek said, you will need histology, but in upper GI, at least for all therapeutic procedures, you will be asked if you contacted the patient regarding complications. Again, after finishing a case, sometimes you need to refresh the web page, so it allows you to start a new one. And as Raf already told, so you should try to at least upload 100 cases, although around 300 should be enough, and you do not need to put all your database. So why to use the app? So several reasons. One of them, it is for free for ESGE members. And as I will show you also in the video, after you upload just one case, as Marek showed you, you will get immediate feedback regarding your own or your department performance measures, depending if you are just putting your cases, your own or from your department. And you will see a chart like this with all the performance measures and the current, what they stand for, and your current standard regarding that performance measure. So KPM, it's a key performance measure, and the MPM, it's a minor performance measure. And this is for the 11 that we have chosen for the upper GI. So recalling our guideline from 2016, so like in the colon, we have key performance measures and minor performance measures. In the upper GI, we have 6 key performance measures and their respective threshold that we should achieve. And we have 5 minor performance measures with the respective threshold again. So at least you should try to get these ones in your department. And after getting these ones, you can go also to these ones. But from the app, you can get the 11 at the same time just using the app. And I will show you how. So I will show a case. It's just around 3 minutes. And probably it's the longest case, which should be Barrett surveillance. So I will just put the video showing. Let's see if it works.
So let us upload our first case. So after doing your login on the app, you will see the upper GI program and the lower GI program. You just click on the upper GI. We want to add a new case. Yes. Was the duration recorded? Yes. How long does it take the endoscopy? So we took 10 minutes for this endoscopy. So, and afterwards it will show you immediately your performance measure for that specific recording of the duration. So this will be a Barrett's patient, a surveillance. So it's a Barrett's. So we need to put the age of the patient, let's say 65 years. Was there any contraindication for biopsies? No. What was the indication for the endoscopy? So in this case, it was a known Barrett's aiming for surveillance. Barrett's surveillance. How long did the patient fast for liquids? In this case, it was more than 6 hours. And the same for solids. Again, your current key performance measure regarding fasting. Could the procedure be completed? Yes. What was the prior classification? So we used it, and we will call it was a C4 M5, and then it will ask about esophagitis. So there was no esophagitis. Was there any visible lesion? Let's say it was with no visible lesion. So again, your current performance measure regarding the standardized terminology. Photo documentation, were pictures taken? Yes, we took pictures. Was there any abnormal findings? No, so it's not applicable. And regarding photo documentation, you can tick all the boxes that we saw. So in this case, we did a full endoscopy and then we inspected the Barrett's, but there was no abnormal findings, so we leave this blank. Again, our current standard for photo documentation. So we measured the inspection time for Barrett's. Yes, we did. So it was a C4 M5 and we took 5 minutes just for inspection of the Barrett's. So again, our performance measure, not so good in this one. Was the Seattle protocol used for biopsies? Yes. Again, our current performance measures. And finally, did the patient was entered in a Barrett's registry? Yes, it was. Again, your standards. And we finished. So you will see care monitor completed with success. And you see that you only see the lower and you should be able to see the upper GI. Sometimes you need some seconds. Sometimes you should refresh the page. So it come again. So now I will upload a second case. So you see again the upper GI app. You click next. And now the first thing you see is your current performance measures. All the 11 that we have for upper GI, which one stands for, and the current standards that you have.
Okay, so this is a video with just one case, and the idea is just to show that even if it is probably the longest case with a direct surveillance, in 3 minutes it is possible to upload a case. And you see that you have a lot of questions, and because you have criteria to make all the calculations, and that's why the app is quite interesting, because by the end, so every time you ask a question, you answer a question, you will see the performance measures, but every time also that you will start a new case, you will see in this case, the 11 performance measures and how you are standing after all the rest that you have uploaded by now. And the main relevant thing from the app is that it makes all the calculations, because it gets, depending on the questions, all the inclusion and exclusion criteria immediately. So what are the results that we have already with the app of the upper GI? So we have all around 3,000 cases uploaded in the past year. So if you look to the 6 performance measures, the key performance measures, so this is the numbers that we have relating to each of the performance measures. So this is the target that was suggested for us in the guideline, and you will see how we stand. So the first thing that you should see is, in fact, although we suggested these standards and these targets, and if you read the guideline, and I hope you did, you see that the relevance of the literature for the upper GI is not as good as in the lower GI. But even though we have this data, we didn't manage to reach any of these protocols, although better, for instance, in the fasting and for the standardized terminology. But for instance, the registration of complications is just a little bit above half of it. So we really need to improve not just our colonoscopies, but also in upper GI. And if we go specifically to photo documentation, so it's possible, because you have to tick all the boxes. So to see how are we, if we are missing any more relevant part, is more or less the same in all the stomach. Although, for instance, it seems that at least we are forgetting in the proximal esophagus to take some pictures. And if we go specifically to the standardized terminology, so you see that we use much more Los Angeles classification, that, for instance, the Zargar classification. You see that most people will not forget. Sorry, something moved here. So I want to go one back if possible. I think it's my internet that is not so good. Okay. So although most people seem to be using the, for instance, the LA classification and the Prague classification and the Bovino classification, for instance, Spiegelman seems to be forgot in 1 in every 3 patients. And for Paris, probably people are more using the Paris classification in the colon, and they are forgetting to use it in the upper GI. At least it's what it seems. And for the minor performance measures, so we have 5. Okay, again, the 5 performance measures that reported. So inspection time in the stomach, much more cases that, for instance, the use of Lugol for patients at risk for ACC in the esophagus, which is also normal. But then again, even if the standards are just 85 or 90%, again, the results we cannot achieve not a single standard that we have suggested 5 years ago. So again, the message is we really need to improve our upper GI qualities. And just to repeat what Raf and Mark already told, so what will ESGE will do with all these results? Well, we pretend to create a benchmark to eventually adjust these performance measures in the future. So if you ask for my opinion, I think we have to improve our results in upper GI. And for instance, the thresholds that we suggested are not as high. It's we that we are, as a group, that we are failing, and eventually see the applicability. So probably some of these performance measures will be lost in the future with some technologies. Probably some of them are missing and will come up in the next years.
Okay. Thank you, Miguel. So maybe, I mean, you were involved in the quality improvement committee for the upper GI. Maybe we were a little bit too ambitious with setting the thresholds because there was no good data. So will we use this benchmark if we have to revise the quality parameters to lower the threshold to make it more realistic? Or are there some that you say this definitely needs improvement? This is not good enough. Is 80% more realistic, for instance?
Yeah, well, we might get that decision by the end if we get around 5,000 or 10,000 endoscopies all over Europe with more people using the app. But in my first opinion, and this is just my opinion, it's what it is. So people are starting to get concerned with quality, which is good. But the first idea when they think about quality in endoscopy, they will always recall colonoscopy. So people think about reaching the cecum, taking time to withdraw if you reach the cecum and you didn't saw any polyp, and then remove the polyps and get an ADR of at least 25. And if they do this, they become happy. But endoscopy is much more than that. And it's upper GI, and hopefully in this year we also have quality issues for ERCP and the US. So endoscopy is much more than colonoscopy. We all know that colonoscopy quality started with colonoscopy because it's probably the exam that most of us make like in 80 or 70% of our time of our exams, and we have strong literature showing that few parameters are really relevant for cancer prevention. And for the others, like upper GI and eventually ERCP or US or enteroscopy, the literature is not so robust by now. But we are trying to show that quality is also important in these areas.
Yeah.
So I still believe that the thresholds probably are all right. It's us as endoscopists that we need to improve.
One important question, I think it's a little bit also referring again to colonoscopies, that should we link the performance data to post gastroscopy cancer diagnosis, a bit like interval cancers in the colon?
Yeah, eventually. So one other problem with upper GI is that in fact we are dealing with 3 organs, so esophagus, stomach, and duodenum. And even if we are talking usually about Europe, and now we have here Portugal, Belgium, Greece, and Poland. So you will see that the incidence of Barrett's, the incidence of esophageal cancer, the incidence of gastric cancer, it's difficult to talk in Europe because even inside Europe, we have very different margins between these countries. So a threshold for a gastric cancer detection in Portugal might be probably very different from Poland or Belgium, and that's why it becomes difficult to get a threshold for cancer detection. Eventually, a better thing would be missing cancers, but this is like colonoscopy. This is much more difficult to measure because you need a second exam in a correct time to get this issue, and that's why even for colonoscopy, it's not so easy to measure.
Yeah, that's a more difficult one that probably needs national databases. Anyway, we come back to the role of national societies in a minute. Just one more good question from Jaroslav Regula. If there's nothing to be seen, it's a normal gastroscopy, how many performance measures will be calculated then?
Okay, so by heart, at least the fasting instructions, at least the number of pictures, because we are saying in the European Society that at least 10 normal pictures should be taken, and at least the full time of the endoscopy should also be taken. And it will eventually at least ask you if you saw any pre-malignant condition that will trigger a different workflow. But at least these three will be asked by the app.
Okay.
That means, Miguel, that compared to the lower GI application, in order to get the most of the benefit from the upper GI, you should have a wide variety of cases of upper GI endoscopies in the department or performed by yourself.
Yeah, and that's why I put in my slide that you should take at least 100, but I would say that for upper GI, probably 300 would be the best. Yeah, because we have more normal exams and more different pathologies.
Yeah. But just imagine that there are not so many centers that they will perform dedicated endoscopy for a Barrett's esophagus. So anyway, the point is that although the application provides the opportunity to measure different performance indicators, you probably do not need all. So it can be adjusted to the facility, and it can be adjusted to the endoscopy needs.
Yeah, of course.
I think that's a very important point, Kostas. So it depends on what you're dealing with. I think even ADR, if you're only seeing IBD patients, ADR doesn't make sense. So I think everything that you measure should be put in perspective of your practice. And if you live in a country where there's no Barrett's, just measuring those 2-3 Barrett cases does not tell you anything about what you're doing in your upper GI practice. So that's a very good point. So everybody has to look within your country. And I think that's why the role of the national societies is so important. So maybe Miguel, you can illustrate what you did with the Portuguese society to improve upper GI.
Okay, so just a few slides on what we have been doing in Portugal, and I hope there are people from all other national societies seeing the. So Portuguese perspective. So the Portuguese Society for Digestive Endoscopy has more than 40 years by now. And one of the initiatives was to have a quality committee, just similar like the European Society. And we have been trying to improve quality by several means, including publications, meetings, queries to our partners and members. We developed a security checklist that I will show you, and we are trying to certify reporting software companies if they prove that they have reporting of the quality of the systems. And finally, we hope with these strategies to promote quality assessment and demonstration, and I will show that at least some SPED members seem to be showing their results regarding quality. So just to show you some publications and meetings that we have been doing for more than 10 years, and not only upper endoscopy, lower endoscopy, and quality in general. So we have specific meetings and publications just for quality. Also, we had 2 queries in the last 15 years. So just to show you that in 10 years difference, so we had no high definition scopes in 2006 for those who responded in Portugal, and how it improved in 10 years. And the main thing was also see the difference in the automated disinfection that was changed in Portugal in the last 15 years. So it was a tremendous job that we did. And also the reporting software was not even a question in 2006 because everybody was doing just plain text and Word files. And then specifically regarding the reporting software, it was not as good. So most people had the reporting software, but see the results that it was not possible in most cases to see if the patient signed an informed consent. It was not possible in most cases to report the duration of the exams. The quality of the bowel preparation uses standardized scale. Only 1 in every 5 systems allowed it. The use of standardized scales was also not much available. And even the level reached in colonoscopy was not able in all reporting systems. So we started to have reporting systems, like Raf showed you in the first slides. They are still far away from what we need. And again, it's another option and another reason to use the ESGE app to do this. Also, we started to do a security checklist, a little bit like the aviation do for going on a plane. So we started with a manual thing that was, and it's available on our website. And then now some companies are doing this. So we have checklists that we can do before the procedure and after the procedure to increase the quality and the security for our patients. And now we are starting to have reporting software. Some of them give these nice charts like the cecal intubation, the adequate rate of preparation, and also the adenoma detection if it links to the histology. But at least most reporting softwares by now are at least allowing to get an output of an Excel sheet so that people can address their quality standards if they don't have these nice charts. Or I would suggest by now use the app from the ESGE, but instead of working on an Excel sheet, you will get the results just by itself. And last month, we just certified as the society, the first reporting company that is providing all these results so that people will get an immediate feedback on their quality if they want to. And finally, just to show you some results from the last year, 2017 and 2018. And this is quite interesting because you see someone that made a publication just regarding the adenoma detection rate. And I will show you yours if you show me yours. And then an article, this is in fact is from my department, saying that quality in colonoscopy was not just the adenoma detection rate. So it's more than adenoma detection rate. And a publication from Myers department showing that how, and this was for upper GI, so we are moving from colonoscopy to upper GI, so how a simple an audit without the ESG app could improve the results just by seeing in 2 or 3 years difference and going on the database and seeing how they could improve if the people were looking for colonoscopy. So this is the message. So when we start talking about quality, lower GI, upper GI, and others, people start caring and people will start reporting. So they are not waiting for politics or for the policy to judge us, but they really want to show the good job they are doing. So this would be my message from the Portuguese side.
It's an excellent effort, I think, and it nicely illustrates that what you can do as a national society and what we really encourage everybody who is engaged in the national society to take part in. And actually, one of the returning findings, I think, and I think that was also the case in Portugal, is that once you start auditing, automatically the quality improves. People are aware that they can do better, and that is in the end game. And another thing that national societies can do is actually to look, like what Costa said, is what is the priority in our country. So we, in Belgium, we had a survey and asked the top 5 of each of the performance measures within the different fields that should be addressed. And this is then something that you proactively as a national society can take forward to the regulatory authorities. So rather than then coming to you and say you need to make sure you meet the bars for all the 11 key performance and minor performance measures of upper GI, or you will lose your license. I think we can proactively say, okay, these are important according to the society and the members, and maybe we should start with this top 5. If we can raise the bar for these 5, like photo, and usually what we find is photo documentation, duration of the procedure, like simple things that already increase the quality and where there is already some good evidence for. And this is, I think, very nicely how you illustrated how national societies can take things forward.
Yes, thank you, Ralph. Thank you, Miguel. Thank you, Marek. But even just spreading the word by the national society, it might be enough. You know, if
Yeah.
someone hears that something is measured or this is measured this way, then if you measure, yeah, then you improve. So even spreading the word among the society members, advertising, promoting, and things like that, because you know not all the national societies have the authority to provide incentives or to penalize. So even spreading the word of quality and spreading the word in a customized manner like we do in the ESGE, then it can improve quality.
Yeah, for sure, for sure.
So thank you very much. And as the times go by, it's time now to say goodbye. As we do with all previous recording, this recording will also be posted in the learning section of the ESGE. So if someone has missed it or someone has missed the previous webinars, then he or she can check them out at our site. And of course, I have to say thanks to the governing board of the ESGE because they gave us the opportunity to have this activity, and especially to our webinar team, Dave Inger and Gabriela Varga, and all the other people which are just behind the scenes and helped run this webinar so smoothly. And we discuss about the ESGE Quality app, but there are also other benefits like the ESGE Twitter for our individual members. So join the ESGE family and please register for the ESGE Days 2021. And finally, our next webinar will be next Wednesday on the endoscopic therapy of esophageal or pharyngeal esophageal bleeding. So thank you very much for being with us. Bye-bye. Enjoy the rest of the evening. Au revoir.
Bye.
Bye-bye. Take
Bye.
care. Bye.
Bye. Take care.